morning, everyone. Hope I'm audible. And we are here today on our breakfast at talk. So today, the first speaker will be Associate Professor Dr. Rukumani. She has been in our Department of Medical Microbiology since 2011. And she is a senior member. I would say her experience in mycology is vast. She has vast experience in mycology, and her contribution in mycology is significant. And this is evidenced by her role in as a ambassador, senior ambassador of ISHAM, International Society of Human and Animal Mycology. She has also been appointed as council member of ICID, International Society of Infectious Diseases, and as such, she has many other memberships in renowned societies related to her field of studies. So she has also been invited many times as an invited speaker to international conferences. And today we are here to listen to her topic on emergence of antifungal-resistant Candida auris, a growing concern, current status and future perspectives. Let's welcome Associate Professor Dr. Rukumani to share her findings and her clinical experts in this field. Thank you.
Good morning, everyone. Thank you, Prof. Chandra, for the kind introductions. Without further ado, we start our presentation today. So my topic is emergence of antifungal-resistant Candida auris, and a growing concern and the current status and future perspective. Basically, new name for Candida auris now is Candid or Zyma auris. So you can remember Candid or Zyma auris. That is the new name that given for Candida auris now. So let's start with a bit of epidemiology and fungal disease incidence and deaths. So you can see Denning is a very famous mycologist, has estimated 6.5 million fungal infections annually with 3.8 million deaths will occur by 2023. And you can see that fungal diseases wholly or partly responsible for 6.7% of all global deaths, surpassing the impact of tuberculosis, malaria, hepatitis, and pneumonia. So you can see the chart here, 1.8 million annual estimated deaths were by invasive Aspergillus infection, and second by the invasive Candida infection, almost 1 million, and others, chronic Aspergillus and other severe fungal infections. With that, WHO, because this pathogen has been rated as an urgent threat by CDC, so this has been classified into critical priority group by WHO in 2022. So the critical high group and medium group, you can see the list of the fungal pathogens which has been classified in this group. Critical group, you can see Cryptococcus neoformans, Candida auris, our friend here, Aspergillus fumigatus, Candida albicans comes under critical group. High group are the Candida glabrata, now known as Nacasiomyces glabrata, and others, Histoplasma, Eumycetoma, and Mucorales, and others, so far and so forth. And medium group were like also classified. We occasionally see in our clinical lab Scedo, Lametospora, Coccidioides species, Pichia cordea vesavi, which is previously known as Candida krusei, Cryptococcus gattai, Thalaromyces we do see quite a bit here, and others. So these are the some fungal priority pathogen list. So basically, Candida auris or C. auris, a paradigm shift for Candida infections. This will act like a bacteria, which has been discovered in a year of 2009 in a ear infection of the Japan patient, which eventually become whole spread. Almost it has been spread and reported over 47 countries worldwide eventually. Epidemiology, a bit of epidemiology of Candidozyma auris. It has been increased from 476 in 2019 to 1,471, almost like 2 to 3 times more. And other continents, Europe also has been reported the cases quite high. Candida auris also detected in almost 100 hospitals in South Africa, which is causing candidemia infection mostly. And India also reported a lot of Candida auris in intensive care units, which causes the 5% of the cases of candidemia. Let's talk about a bit of COVID and Candida auris, which is health-threatening combinations because co-infection by Candida auris are quite rampant during this time because persistence on hospital surfaces and high resistance to antifungal drugs are the significant value, and COVID-19 has provided important potential bait for these infections to occur. ICU have the greatest risk factors for such infections. So basically, in this paper, they have said that too much and inappropriate use of antibiotics, disinfectants, and biocides during this pandemic, which causes the increases in the Candida auris during this COVID pandemic time. Okay, so let's talk about my experience working with Candida, Candido-Ozima auris. So what we did some bit of a molecular characterization and antifungal susceptibility testing of Candida auris from our center here. So this is our lab, small lab. We have a diagnostic lab fully automated for yeast identification since 2018. You can see it's a small machine multi-top here, white tag, and all those things are here. Okay, so we did some research. Our research objective is that to determine the isolation rate of Candida auris from sterile specimens obtained from ICU and patient admitted to UMFC over 4 years period, and to analyze the molecular epidemiology of auris isolates by multilocus sequence typing, MLST, and whole genome sequencing, and also to determine the antifungal susceptibility profiles of UMMC of Candida auris isolates from UMMC. So let's go through the cases, 4 cases of Candida auris. So patient 1, we will classify it as patient 1, patient 2, patient 3, patient 4. Almost all of them are elderly. I mean, female 74, patient 2 is 64, male 82, and female 72. So they all had underlying conditions and diagnoses. Patient 1 had cluster-kin tumor and cholelithitis, and patient 2 had MP matherosis, sigmoid colon carcinoma, and infected big tooth. So patient admitted on 9, 2018, and isolated the Candida auris were isolated on 6, while patient 2, these are the admitted dates, and the patient 4 has readmitted again. So this is isolated date whereby we isolated Candida auris in their blood or anywhere in a CBL tip and things like that. So basically, this admission date culture positive was 72 days, and patient 2 at 27 days, and patient 3 is 71 days, and this patient only 2 days. So where we isolated Candida auris is that this is CLB tip in ICU, blood CNS, peritoneal fluid, and blood CNS again. These are the place where we isolated Candida auris in this patient. Okay, so antifungal therapy for patient 1 started for almost two weeks, so total about 39 days. Patient 2 is antifungal 33 days. Patient 3, 51 days, and patient 4 had 19 days of antifungal treatment. So these are the diagnoses, okay, CLAP-C, CLAP-BSI, intraabdominal sepsis, and BSI, all, and the diagnosis dates are, these are the diagnosis date, you can see that. So what other antimicrobial treatments they have it. So these are the patients had multiple antibiotics treatment. You can see Tazo, Ocmetin, Unacin. Okay, all of them are there. And this patient also many antibiotics treatment were given previously, and this patient 3 and patient 4 had only one antimicrobial treatment given for patient 4. So all having risk factors, CBD intubated, acute kidney injury intubated, okay, AKI, all these some risk factors are there. Comorbidities also seen in this patient, hypertension, diabetic, this patient 3 and patient 4 had hypertension only. So all of them died, okay, but except this patient 4 escaped and she discharged. Okay. So retrospective data analysis, we noted that we collected Candida species distribution from sterile samples alone from ICU ward from January to December 2021. You can see these are the Candida species which has been seen, and number of isolates during this time and this isolation rate. So Candida auris about 4.9%, isolation of Candida is 4.9% compared to other Candida species. So this is the the isolation of Candida auris in MSC is significantly lower than Candida albicans, Candida tropicalis, and Candida parapsilosis. Yeah, but so this is the retrospective data analysis during that week where we did investigation on Candida auris. So what we did, we followed on to do multi-locus sequencing typing. So you can see demonstrated heterogeneous populations. So Malaysian UMC strain similar to MLST type here. Strictly one reference strains with Pakistan and India were genetically related to Malaysian strains may belong to the South Asian clade. So this is a Malaysian strain here, Malaysian. So they are all related to the clade one, which is related to Pakistan and India sort of a strain. Okay, so 5 geographically distinct Candida auris clades have been described in literature. So clade 1 is South Asian, which is ours as well. We are together in Malaysia. And clade 2 is East Asian. Okay, and clade 3 is African, clade 4 is South American, and clade 5 is Iranian. So this is our MLST test result. So we did comparative genomic analysis as well. So you can see 5 comparative analysis of Malaysian genomes are highlighted. So Malaysian Candida auris strains belong to South Asian clade, clearly can be seen here, influenced by geographical factors. And different clades may have different antifungal susceptibility profiles and gene mutations. So Candida auris isolate from clade 2 to be less invasive and have lower propensity to cause outbreaks. So this is why you have to check this genomic analysis and where our clades are coming from. So ours is in clade 1. Okay. So these are some distribution of Candida auris, the most prevalent with the occurrences reported in 17 countries. So ours is here. Okay, so ours is clade 2. Sorry, ours is clade 1 actually. Okay, so these are the things. Okay, emergence of 6 clade, this is clade 4, clade 6 of Candida auris in Bangladesh has been reported. So this could be a potential for international transmissions. So antifungal sensitivity results showed that 80% of the Candida auris isolates were resistant to fluconazole and voriconazole. So compared to us, you can see our sensitivity pattern and the result. And clade 6 isolates were susceptible to azoles, echinocandins, and pyrimidine analog. So this is the newest clade has been identified and in Bangladesh. So our antifungal susceptibility testing, you can see that the 4 isolates, amphotericin were resistant, okay, and fluconazole also highly resistant. So other echinocandins like caspofungin, micafungin, anidrofungin are all quite sensitive, and posaconazole, voriconazole, itraconazole, and 5-fluorocytosine all are also quite sensitive. So this has been defined, these breakpoints based on Candida species. All right. So our summary susceptibility testing results shows that all isolates exhibited resistance against fluconazole and amphotericin B, while all the isolates were susceptible to micafungin, anidrofungin, and caspofungin. A single Malaysian strain from 2017, which is reported by Muhammad Tai at his report, saying that one auris were resistant to amphotericin B, caspofungin as well, and fluconazole. So this has been reported. There is isolated caspofungin resistance noted in Malaysian strain. Previously isolated strains from South Asian countries also exhibited resistance to fluconazole followed by amphotericin B. So this is a summary of the testing, susceptibility testing result. Resistant mechanisms, again, Mostly azole resistances occur when ERG111 genes mutations occurs at the genes, while efflux pump overexpression of efflux pump in this gene pushes drugs out. And acute resistance usually occurs due to the FKS1 mutations, shield glucose synthase from drug targeting, and amphotericin B resistance usually occurs in this gene, ERG2, ERG3, to reduce ergosterol, weakening the drug effects. So let's see what our isolates are, which genes it has possessed to to have this resistance pattern. So you can see this is our isolate 1, 2, 3, 4. It has got a mutation at ERG11, fluconazole resistance noted, and one isolates were mutated at CDR1, fluconazole resistance, and we noted some novel G1414E mutation in CDR1 noted in this gene, but we are not so sure what is the implication about these novel mutations beyond antifungal resistance. While other mutations were ERG2, with amphotericin B resistance also noted in this mutation analysis in our isolates. So no mutation sites were identified in these genes associated with echinocandins and flucytosine resistance. So this is the antifungal resistant mutation results. So what we learned, lesson learned from our clinical cases, mostly elderly, cause invasive infections, predominantly fungemia, high mortality, and all having risk factors of CBD, prolonged antibiotic use, presence of central venous catheter, and intubation. Comorbidities also is noted together with these risk factors, mostly having hypertension and diabetic, some of them only having hypertension. Prolonged hospital stays and culture positive more than 48 hours. And multi-drug resistant strains, previous broad spectrum antibiotic usage. All these things are similar clinical cases with other review papers as well. Interesting facts about Candida auris. It is multi-drug resistance, and it can survive up to 2 weeks on plastic surfaces and viable but not culturable state for at least 4 weeks. That's about a month. So it is viable but unable to culture in your lab. So it can be there for 4 weeks. The most common risk factors for expositions are invasive devices and being immunocompromised. And also Candida auris showing predilections for the skin, exactly like Candida parapsilosis. They both have these predilections for the skin. Production of biofilm, phospholipases, proteinases, and secretory proteases all are very important for them to stay longer in the invasive indwelling catheters and things like that. Rise of Candida auris infection could be partly attributed to the worldwide increasing in the use of antifungal drugs, okay, and climate changes, selecting the thermotolerant yeast. This Candida auris can grow up to 42 degrees. It's one of the important valence vector of Candida auris. So you can see the recent discovery of Candida auris in the oral cavity of the dog supports the hypothesis of zoonotic transmission. Just hypothesis, not sure. So probably climate changes, global warming with emergence in wetlands, okay, high temperature and high sodium salinity, which can possibly intermediate host will be harboring these, which is possibly disseminate to the global disseminations, which eventually get into the hospitals and causing cluster of outbreaks. Okay, global concern, yes, definitely we are all very concerned about Candida auris because it is multi-drug resistant and can be pan resistant as well, difficult to treat. Some isolate resistant to all three major antifungal classes, and acquired resistance can be also possible. Some isolates from India, about 2 or 3 isolates from India has been pan resistant, also has been reported. It is also can be misidentified. Usually misidentified as Candida species like Candida famata, Candida himolani, pseudohimolani. All these things can be misidentified if you are just using biochemical test or API strips or Vitek. These are all old biochemical methods when we used to identify Candida species in lab. So if you use this method, you're definitely going to misidentify Candida auris. And as cost outbreaks in healthcare setting is still causing a cluster of outbreaks. Unlike other Candida, seems colonized healthcare environments, heavily colonized uh, Candida auris, major infection control challenges, okay, co-infection with COVID and clinical cases reported continued rising since 2016. Okay, future directions, funding investment in mycology really required, and robust treatment protocols, okay, synergetic combinations if it's possible, and research and antifungal drugs and diagnostic capacity and advanced diagnostic methods are required, especially you're looking at Candida auris. So, special interest as like antimicrobial and stewardship, antifungal stewardship also required, but is quite new in Asian perspective. So basically, the same sort of aims to optimize antifungal use, to limit antifungal resistance, to improve outcomes, to increase awareness of fungal infections, with that may alter prescription practices, and of course, the most important one is infection control measures as well. So basically, the transmission-based precautions are recommended: alcohol-based and sanitizers, hydrogen peroxide, chlorine-based disinfectants, and iodine-based chlorhexidine antiseptics are effective, but we need um, uh, more studies on this transmission. I mean, those this antiseptics usage and hand-based sanitizers. Activity of resafungin against Candida auris is a newest drug for Candida auris. Therapeutic activity of resafungin against Candida auris. It is reasonable that resafungin may be a viable choice for treating candidemia and inhibiting candidiasis caused by Candida auris, but we need further clinical investigations are very much required for using these drugs. Okay, infection control measures as like per like a view. So basically, it starts with accurate species level identifications. Okay, we use multitoph and sequencing. All these things are required. Typing is required as well. You're going to look for the genes, resistant genes, as well as which clade it came from. And these are the some transmission-based precautions which I already talked to you earlier slides. Okay, so with this research, we managed to publish one paper, Emergence of Genomic Profiling of Multi-Drug Resistance Candida auris, isolated from Jessica. These papers are available, can download easily, and and other publications from this research and investigations. We had Candida auris, a mini review we have published, and also Candida volchana, a new emerging Candida, which can act like exactly like Candida auris, having a lot of multi-drug resistance and difficult to treat. So with that, thank you so much. And this is my last slide. Thank you very much.
Thank you, Prof. Ruku, for that excellent presentation, enlightening us with the epidemiology, the resistance, the drug of choice that can be given to patients, to treat patients, and also on the future directions, as well as about the Candida volchana as well. So with all this, I'm sure the audience have benefited quite a lot on this 25 minutes session. Any questions from the floor?
Okay. Yeah, I saw Dr. Helmi has given some questions here. Hi, what diagnostic capacity do we have at UMMC for Candida auris? Yes, we have multitoph. Yeah, it's very good. We have all these because we have multitoph. We have it from 2018. I think it's very updated to the to now. So we have very good capacity to identify Candida auris, as well as we have PCR PCR as well. So in case we have some sort of like some sort of like you have like so like Candida hemoloni or Candida famata or something that very resistant pattern, we even we do multitoph, so we will also counter check with PCR. So our diagnostic capacity is quite advanced actually. Yeah, thank you for the question, Helmi. Yeah, yeah. Typing is not available for diagnostic, but research we can have it. Yes, yeah. If we did it by the research. For research, we did typing. Well, for diagnostic, we just do just basic diagnosis only.
Okay.
Okay. Which Candida species? It's a general Candida species. I don't specifically, there's like 2022, before this, the five major breakpoints came for the specific Candida species. We have 2018, we have one CLSI where we have Candida species for general sort of a breakpoint. So I used that as in like even it is just like some sort of random sort of breakpoints because there is no any valid breakpoints in CLSI for Candida auris, right? So it's just some sort of like a general sort of interpretation and just look through the Candida species which was on 2020 or 24 before this 2026 had this, no, sorry, 2024, we had this valid breakpoints for 5 species. And before that, if you see the CLSI journals, they have this they have this Candida species for general breakpoints. So I used that
For the
to
new
gain some
agents?
resistance. What would you threshold for testing this new agent in case we need to use to reach out? Yeah, these novel agents do we have? Well, we don't have a break point as such, but we can, because I think we'll see what we can do, but we don't have break points. Right? I don't think so. We haven't have this resafangin and phosphomonogapics also not here. But if it's come under research, if the drugs are available, we can sort of look through research part of it rather than diagnostic. Yeah, thank you.
Okay, I think that's all. I have a question, Prof. Ruku. So if at all, um, because now in UMMC we have multi-TOF to test or to identify um, Candida auris or Candidozyma auris. So what is your advice for other hospitals? Do you like advise them if you see such resistance and the conventional way of diagnosing is showing Candida species? What will be your advice for such people? Where do you think they can refer to? Is it a UMMC or is there any other place they can refer to know that it is really Candida auris?
Okay, right. Anything from the, thanks for the question, Dr. Chandra.
Yeah,
Okay, anything from the sterile side, better to speciate. And
yeah,
if you see, my previous discussions, you see a lot of risk factors, prolonged
yes,
antibiotic,
yeah,
patients are not responding to the antifungal treatments. If you have some sort of suspicious, please send the isolates to the either UMC, we can help out, and there is IMR doing, that's the main center. The isolates are sent there for further identifications as
thank
well
you.
as sensitivity testing. Yeah, it can help out at least. Yeah,
Thank you so much. Thank you so much. Yeah.
thank you very much.
So if is there any other question? Let me check. Oh, I think all are asking about a breakpoint actually. So I
Yeah,
think that you have
I can't
already
see. Yeah,
answered.
where is it?
Yes.
Yeah, yeah, just hold on. I can't see. Yeah,
Yeah,
just let me
you
check
have to
it out.
scroll
Yeah.
down. Yeah.
Uh-huh.
So what is a breakpoint?
Okay. What is breakpoint? Oh, breakpoint is where there is a, okay, every pathogen has got their own breakpoints. If you know, like let's say Staphylococcus aureus, we have some certain breakpoints in CLSI. CLSI is there is one booklet where you can see that this breakpoint is sensitive. This breakpoint is resistant. Like let's say Staph aureus 0.01, less than 0.1 is sensitive, more than more than 2 microgram is resistant. So these are the some breakpoints that given by the CLSI person. It is in so it is basically you sort of like report it using these breakpoints, as in like whether it's sensitive or resistant for every pathogens. Like Candida auris got their own breakpoints, Candida albicans has their own breakpoints, Candida tropicalis has their own breakpoints. Yeah. Okay.
Okay. So thank you so much for the questions from the audience and as well as to the speaker, Prof. Ruku. So I think we will hand over to our next speaker. With that,
Mm.
thank you from us.